Good evening, everyone. Greetings from Leeds. In implant dentistry, we need to start with looking at the palatal bone. So many times we take CBCTs and we start looking at sagittal and we start to look at that labial plate, which is important. But I would recommend also looking at the axial view and look at that palatal bone. Because if that palatal bone is too thick, it might drift your implant too labial. If that palatal bone has a defect, you might need to put the implant in the right position and build that palatal bone rather than place the implant again too labial. Obviously, labial plate is important because, as you will see later on, to get a proper GBR, you will get better results if the defect is contained, what we call three-wall defect. So this is what we're talking about. So we're gonna get a palatal bone. We're gonna check that, make sure there is no defect, and if there is defect, it will change our treatment plan. We're gonna talk about the labial plate, and we already understand the importance of the labial plate to contain the GBR, to provide the support, and to provide obviously the source for the blood vessels and all the good cells. And then you need to choose the correct size of your implant. In the past, we used to think go for wide implants to give us mechanical stability. And this is right. The widest the implant, the more mechanical stability you're going to get on the long term. However, we do understand now that if we go for a wider implant, we're going to invade the space which should be filled with bone for protection. So nowadays, we go, and our recommendation is to go for the narrowest implant mechanics allow you, or go for the widest implant biology allows you. So it has to be a multifactorial decision. We never go for very wide implant in the anterior region, full stop, period. Now, that gap, ideally, we want to have a labial gap. In ideal scenario, that labial gap needs to be bigger than the palatal gap. If it's other way around, you know your implant is placed too labial, and you're going to end with an implant compromising the labial plate, giving you recession within a year or two. So we always like to maintain that labial gap. Now, in the past, I used to remember they were teaching us if the gap is less than 2 millimeter, leave it alone. There is no need to graft that gap. Well, nowadays, I can tell you the recommendations we pass to our colleagues, the Bird Academy, that if this gap is fillable, it needs to be filled, because you might use that labial plate. Most likely you're going to lose it. You want to have something to protect your implant. So you put some bone in that gap. And we're going to talk later about what's the ideal type of bone to fill that gap. And then we need to achieve that convexity we were talking about. You could decide to go for some type of bone augmentation to ridge contour that area, or you might decide to use soft tissue graft to contour that area. It's up to you to decide what you want to do. But what I don't want you is to just ignore it and do nothing. And that's why I never go for flapless implants in the aesthetic region without any further bone or soft tissue management for that convexity. You could go flapless and could do tunnel technique and put connective tissue graft if this is what you want to do, fair enough. But you cannot just put the implant, fill the gap, and hope for the best, because in no time, and we've seen it within 2 years, you're going to lose that labial plate and you're going to have that concavity, which is going to be like a shout out, this is a false tooth. And then obviously, if you're going to do some ridge contouring and ridge augmentation, we will talk to you about the importance of stabilizing that membrane. Because we know now, if the membrane isn't well stabilized, that guided bone regeneration, that ridge contouring is not going to be as predictable, as reliable as you would like it to be. So basically, this is what we want to do. Start by looking at the palatal bone. Place the implant as palatal as possible within the socket in an angle to allow the head of the implant to come out in the cingulum region rather than in the incisal edge or in the labial wall. And obviously, I'd like to extend my gratitude to you. Thank you very much for giving me your time and for being here with me in this webinar. And stay positive, stay strong, stay happy, and I wish you all the best. Thank you very much.